team along with Dr. Palaniyappan sir and the team for giving us the opportunity. Dr. Saravana Kumar sir is held up for some urgent personal issues, so he is not able to join the meeting. So Shanti ma'am, shall we start the case presentation? Shall we? We can. Dr. Adan and Dr. Pavitra, they are starting the case presentation. So over to PGs, Dr. Adan.
Thank you, ma'am. Good evening, ma'am. Myself, Dr. Adan, and Dr. Pavitra will be presenting today.
Yes, please start your presentation.
Yes, ma'am.
You can start your presentation.
Okay, ma'am. Thank you, ma'am. We'll be presenting a case on peripheral neuropathy based on approach to peripheral neuropathy.
Okay.
Go for the next slide. Dr. Adan, go for the next slide.
Ma'am, actually, we are hearing our own voice again, ma'am.
Change the slides. Is it moving?
Is your Wi-Fi okay? Just check.
Yes, ma'am.
Yeah.
Slides are moving?
No, I think they're having some issues.
Yes, ma'am. Wi-Fi is good.
Okay.
Ma'am, but I'm able to hear what I'm speaking again, ma'am.
Are you able to hear we people talking?
Yes, ma'am. We are able to hear you talking, ma'am. But
okay, proceed. We will see how it reflects. Then, according to the IT coordinator's instruction, we will make a change.
I'm able to hear what I'm speaking again, ma'am.
So are you able to hear?
Yes, your voice is audible.
Okay, proceed. We will see how it reflects. Then, according to the IT coordinator's instruction, we will make a change.
I'm able to hear what I'm speaking again, ma'am.
So can you go to a different then? Yeah, please start.
Yes, your voice is audible.
Okay, proceed. We will see how it reflects.
Your voice is clear now, Adan.
You coordinator's instruction, we will make a change.
I'm able to hear what I'm speaking again, ma'am.
Oh, you're not able to hear us, is it? Yeah, please start.
Yes, your voice is audible.
Okay, proceed. We will see how it reflects.
Your voice is clear now, Adan.
You coordinator's instruction, we will make a change.
I'm able to hear what I'm speaking again, ma'am.
Oh, you're not able to hear us. What's some other thing, no? Come by from your cell phone then.
Yes, your voice is audible.
Okay, proceed. We will see how it reflects.
Your voice is clear now, Adan.
You coordinator's instruction, we will make a change.
I'm able to hear what I'm speaking again, ma'am.
Oh, come from your cell phone then. Come from a different thing. Come by your cell phone then.
Yes, your
Palaniyappan sir.
Okay, proceed. We will reflects. Clear now, Adan. You coordinator's instruction, we will make a change.
What I'm speaking again, ma'am.
Oh, come from your cell phone then. Come from a different thing. Come by your cell phone then.
Yes, your
Palaniyappan sir.
Okay, proceed. We will reflects. Clear now, Adan. You coordinator's instruction, we will make a change.
What I'm speaking again, ma'am.
Oh, come from your cell phone then.
In this invitation. Dr. Uma Devi, hello.
Yes, sir. Yes, sir.
Yeah. On behalf of South Zone, South Mid Zonal API, PG Masterclass, our heartiest welcome to all the moderators and professors. Heartiest welcome to Dr. Uma, Dr. T.S. Shanti today's program, and Meenakshi Sundaram. And today, we are. Hello.
Yes, sir, you're audible.
Today we are going to have a discussion on peripheral neuropathy. Dr. Pavitra and Dr. Adan are going to discuss two cases. Our professor, my dear friend, Dr. Uma Devi and Dr. Hariharan sir and Dr. Santi will discuss in detail about the peripheral neuropathy. It's a very
Yes, sir.
important practical topic. After completing your practice, you are going to manage a lot of peripheral neuropathy cases. So the approach should be very clear, and a lot of common causes of peripheral neuropathy is, unless proved otherwise, it's diabetic peripheral neuropathy, distal polyneuropathy, DPN, very, very common. And we are having a diabetic painful neuropathy, and there are mononeuropathy in the diabetic patients are there. Mononeuropathy, like carpal tunnel syndrome, diabetic cervical plexoradiculopathy, intercostal radiculopathy, and diabetic lumbosacral plexoradiculopathy. All this radiculopathy you can come across. And peripheral neuropathy, cervical spondylosis with cervical brachial radiculopathy, brachial plexopathy, lot of things we will be managing. So peripheral neuropathy, the another important thing is on when the patient is on metformin, vitamin B12 can produce peripheral neuropathy. Various vitamin deficiencies, various B1, B6, B12 deficiency and folic acid deficiency also can produce peripheral neuropathy, as well as lot of spinal cord diseases also can present with peripheral neuropathy. So clinical examination is vital, and peripheral neuropathy may be associated with various neuropathies like motor neuropathy also. There will be peripheral neuropathy, other neurological deficit, they may be associated. So all the things you have to undergo detailed evaluation. And tropical neuropathy also, you should keep it in mind. Nowadays, leprosy is often forgotten. Now, some of the patients we are looking for the Hansen's disease with peripheral neuropathy. And Hansen's disease, many times, even dermatologists also missing the Hansen's disease. And diabetic patients usually, that is neuropathy with as well as vasculopathy, peripheral occlusive arterial disease with diabetic peripheral distal polyneuropathy. So combination may be there, which will produce non-healing ulcer, tropical ulcer. So always nowadays in the PG teaching, that is ulnar nerve thickening or greater auricular nerve thickening, all the nerve thickening you have to, in day-to-day practice, you have to examine in the presence of any nerve thickening, as well as meticulous examination, presence of numbness, if the patient complains of numbness, any loss of hair. And many postgraduate students, often if the pulse is not palpable, immediately they will come to a conclusion of peripheral occlusive arterial disease. It's not so. It's one of the macrovascular complication of diabetic, macrovascular complication of diabetes. Usually, if the pulse is absent, there may be a that's anatomically it may be present in ectopic presentation of the various arteries. So unless there is ischemic changes, you should not suddenly jump into that. And limb attack also can present acutely or chronically, it may present. And typically the food examination, presence of any callus or presence of any nail bed also, hair also, skin turgor, all the things, all the postgraduates should examine.
Hello, Dr. Palaniappan, sir.
So the other thing present. So we proceed with the case discussion. Over to my dear friend Dr. Uma Devi and Santi Madam. Over to you.
Thank you,
Sir,
sir.
thank you very much, sir.
Thank you for the extensive discussion introduction. I think the importance of all these tropical causes has to be ruled out. Diabetes is an important thing. So, Shanti ma'am, shall we proceed for the case presentation?
Yes, madam. Yes, madam.
Yeah. Dr. Radhan, can you start the presentation? Good morning, Meenakshi Sundaram, sir. Please start your presentation. Adhan? Dr. Adhan?
Dr. Pavitra?
You are not audible, PGs. Doctor?
Ma'am, are we audible, ma'am?
Yeah,
Yes,
now you are
sir. Yes,
Yes,
proceed with your presentation.
Yes, ma'am. We have a patient, Mrs. X, a 42 years female who's hailing from Thiruporur and who's a homemaker and a right-handed individual and belonging to a lower middle socioeconomic status according to modified Kuppaswamy scale. She presented with chief complaints of numbness of both lower limbs for the past 8 months, imbalance while walking for the past 8 months, and a wound in the left foot for the past 6 months. History of presenting illness. The patient was apparently normal before 10 months back when she developed pain over calf of her lower limbs, which was present throughout the day, not associated with aggravating or relieving factors, followed by which patient had burning sensation over both feet initially and then increased up to the leg at the level just below the knee joint, and it was not associated with cramps. The patient also gives a history of numbness in both feet for the past 8 months associated with intermittent pins and needle sensation below the ankle joints, and she started feeling as if she was walking over a bed of cotton wool. A patient also gives a history of difficulty in insinuating the foot into slippers, which was also present for 8 months. And since then, patient had stopped using footwear. And patient also gives a history of unaware slippage of footwear that was present, but there was no history of tripping of toes. Patient gives a history of difficulty in walking, which she says mostly is because of unsteadiness, and hence patient started using support while walking and started walking only by keeping her head down, like seeing the ground. Following the history, there is also a history of clearing obstacles. Clearing obstacles from the ground, and patient also says that she started using her toes first while keeping her foot while walking. There is also a history that patient gives that she was unable to perceive insect bite over her lower limbs, and there is also a history of inability to perceive hot and cold sensation up to the middle of her leg, mid calves, during taking showers, taking bath. And patient also gives a history that she attained injury over her left heel unknowingly while working in kitchen. Patient noticed the injury only after the formation of blisters, which had progressed to wound for which patient was treated multiple times with antibiotics, dressings, and procedures. There was also history of fever, which was low grade, intermittent.
Adan,
Yes,
yeah.
ma'am.
The previous slide, just show the previous slide.
Yes, sir.
Typically, that is a footwear. Drop in the footwear. Actually, you are telling no, unaware history of unaware slippage of footwear.
Yes,
What
sir.
do you mean by that? What inference you want to give? And unnoticing injury over the foot. Okay.
Yes, sir.
These two finding, what you want to say?
Sir, unaware
Loss of complete sensation.
Yes, sir.
Yeah, tell me.
Yes, sir. Unaware slippage of footwear, usually indicates that patient is not able to perceive the a position or feel the footwear inner. I mean, it's a loss of position sense along with a large fiber sensation loss is what we can inference about that symptom, sir.
Large fiber sensation lost, commonest cause, two important causes.
Diabetes mellitus, sir.
Okay. In your postgraduate student, as a
Yes,
postgraduate student, how many patients with the diabetic peripheral neuropathy you coming across? Usually this history, that is slippage of the footwear, very, very typical finding of especially Hansen's disease. Okay. Hansen's disease. But to some extent, severe diabetic peripheral neuropathy, distal polyneuropathy, large fiber neuropathy, you will get it in diabetes also. Okay.
Yes, sir. Okay, sir.
And especially the Hansen's disease people, they will come with a history of some rat bite
Okay,
over
sir.
the food, rat bite.
Yes.
Suddenly there is ulcer, there is a bite mark, injury, everything. Okay.
Yes, sir. Yes,
And
sir.
especially diabetic patient, after going to the pilgrim stations without any socks, any
Yes.
chappal, okay,
Yes, sir.
they are coming with the blisters.
Yes,
So
sir.
diabetic blisters, diabetic neuropathy will end up in blisters. If you are seeing the blisters, don't take it as a easy. You are already, let's say, dermis, epidermis gone. Dermis also
Yes, sir.
gone. Deep-seated
Okay, sir.
abscess also may be there. It may end up in deep-seated abscess, severe sepsis syndrome, septic shock syndrome, or multi-organ failure. If you don't recognize and properly, you treat. So that's
Yes,
why
sir.
diabetic patient always, if you want to go to the pilgrim station, better
Yes, sir.
you wear the cotton socks everywhere. It's allowed. Should not
Yes, sir.
sit in the buses in the front seat and near the driver seat side. You should not sit. Okay,
Yes,
very heat will affect the foot. Okay, all the advices you have to give. Okay,
Yes, sir.
the
Yes, sir.
slippage and your history of injury, unknowing injury,
Yes, sir.
especially severe distal polyneuropathy with uncontrolled diabetic patients.
Yes, sir.
Patient, footwear only. Actually, many patient footwear, the costing around 1,000 rupees, both indoor and outdoor. Chappal.
Yes, sir.
2,000 rupees is the prescription medicine. It's a main medicine prescription for the diabetic patient. If you
Okay,
don't,
sir.
many patients,
Okay, sir.
90% people, they will not oblige. So you will.
Sir, we are not able to hear you, sir.
Okay, you can continue till sir joins.
Okay, ma'am.
I think sir has lost the contact.
Okay,
Hello?
ma'am.
Hello?
Sir has come. Sir has come.
Hello? Hello? Can I say something?
Yeah, this is very important history.
Hello? Palaniappan
Sir?
sir.
Hello?
Palaniappan sir, can I say something?
Yes, sir. Yes, sir.
This is the Professor Dr. Vijay Mohan
Yeah,
from
yeah,
Hyderabad.
please.
Hyderabad.
Yeah, please, sir. Vijay Mohan, sir, please.
I enjoyed your explanation, Dr. Palaniappan, about the neuropathy, diabetic neuropathy. Just take 1 minute. I got reminded of one of my patients who was a revenue divisional officer. He was touring some villages in a jeep in a hot summer, and without knowing, he removed his slippers and he was putting his feet on the metal floor, which was not having any proper carpet. So by the time he came back home, both the soles were big blisters, and it was so bad that he was just not able to feel the heat, and the whole bilateral soles got blisters, and he had to be admitted. He went into multi-organ failure and he diabetic ketoacidosis and died. So neuropathy, if it is not noticed, it may go unnoticed and can cause havoc in some patients like this. Thank you, sir. Palaniappan, sir.
Thank you. Yeah, thank you, Vijay. Thank you very much.
Yeah.
Yes, Uma, you can proceed.
Yes.
Yes, sir.
Uma Devan Santi.
I'll proceed with the history, sir.
Yeah, please continue, Adan.
Yeah.
Patient also gives a history that she had difficulty in perceiving insect bites over her lower limb. Also inability to perceive hot and cold sensation during up to mid calves, and patient attained an injury over her left heel unknowingly while working in the kitchen. And patient noticed it only after the formation of blister, which had progressed to wound by then, after which she was treated multiple times with antibiotics, dressings, and procedures. And there was also a history of low-grade intermittent fever, not associated with chills and rigor, which was only present for 3 days before she came to the hospital. There was no history of buckling of knees, and patient uses a Western toilet for toilet purposes for the past 6 months. She has been using Western toilet. And the patient also had difficulty in climbing up and down the stairs, so she stopped climbing up and down the stairs for the last 8 to 10 months. And there was no history of difficulty in mixing up the food and with the hand, and she's able to eat without smearing it around her mouth, and she's able to lift her arms above and comb her hair without any difficulties. And there was also no difficulty of wearing her blouse hooks. And there was no history of any sensory disturbances in the upper limbs. And there is no history of difficulty in turning from side to side, and no history of difficulty in lifting head from the bed or moving the head side to side. No history of any thinning or twitching of muscles. And there is no history of any diurnal variation of these symptoms. And there is no history of tremors while reaching for objects. And there is no history of difficulty in negotiating narrow pathways.
Adan, one question. Difficulty in hooking the blouse, actually, the lady's compliance means you are telling one of the different.
Sir, I'm not able to hear you, sir.
The differential diagnosis, peripheral neuropathy you are telling. Okay. What are the other differential diagnoses you have to think in terms? In a diabetic patient, difficult to lift the hand up, difficulty in
yes, sir. A stiff shoulder.
Yeah, frozen
periarthritis of shoulder joints, sir.
Always you have to roll out. Common things are always common. Okay. Yeah,
yes, sir.
Periarthritis shoulder or frozen shoulder. Or supraclavicular tendinitis, many things, subscapular tendinitis, many things are there. Different degrees we will be having the tenderness.
What is the scientific name for periarthritis?
Frozen.
Frozen shoulder is a common term, you know. I'm again Dr. Vijay Mohan from Hyderabad. Specific ortho language word. Adhesive capsulitis.
Yes, sir. Adhesive capsulitis.
Yeah, continue.
Okay.
Please continue.
There was no history of difficulty in appreciating smell. There is no history of double vision. There is no history of difficulty in visualizing or difficulty in vision problems. The patient is able to perceive facial sensation. Patient is able to chew the food properly, and there is no history of any deviation of angle of mouth. And patient is able to whistle, blow, and smile without any problem. There is no history of stagnation of food in the mouth, nor any history of drooling of saliva noted. And there is no history of any hearing abnormalities, no tinnitus or spinning sensation, no difficulty in swallowing foods, no history of nasal regurgitation, no history of hoarseness of voice, and no history of difficulty in turning from side to side. And there's also no...
Define vertigo, central and peripheral vertigo.
Sir, sensation of where a patient feels as the environment around him is spinning. A feeling of... Sir, sensation of spinning of an environment that the person perceives, sir, or either he is spinning or the person is spinning.
Okay.
The patient also gives no history of any recurrent fever. There are no joint pains or swelling, no history of weight loss or loss of appetite, no history of recurrent oral or skin ulcers, no history of any patches in the skin or hypopigmentations, no history of bowel or bladder disturbances, no history of dizziness on standing, no history of abdominal pain, nausea, or vomiting. There's no history of abnormal skin tightening. There is no history of sleep disturbances or seizures or memory disturbance or abnormal behavior or any history of trauma or vaccination or dog bite.
So can you go back to the first slide, Adar?
Yes, ma'am.
So before that, so what is the importance of age with relevance to your case, peripheral neuropathy?
Age, depending on the age of presentation, for example, it will be helpful whether we can differentiate as acquired peripheral neuropathies or hereditary peripheral neuropathies, ma'am. Sometimes patient with, if the patient is going to present in the first decade, second decade, we have to think more towards hereditary peripheral neuropathies like Charcot-Marie-Tooth disease, hereditary sensory autonomic neuropathies.
Okay.
And if there's any history, if there's any young age with male dominant history, again we have to think about Fabry's disease, Tanger's disease, which is usually present in the first, second decades. As the patient gets a little older in the fourth decades or the fifth decades, then we think more about metabolic diseases like diabetes mellitus. If it's a female with the constitutional symptoms, then at an age group of fourth, fifth decade, or in the reproductive age group, you have to think about vasculitis associated peripheral neuropathy. And more elderly age groups, we can think of paraneoplastic associated peripheral neuropathies.
Okay. So that
Yes, multiple myelomas.
alcoholics, yeah, very important. Okay. Go to the next slide.
Next slide, miss.
Yes, ma'am. I'm just.
Next slide. Okay, so numbness, next slide. So here there are sensory symptoms you have told, no? Numbness and all. So can you
Yes,
tell us the positive and negative sensory symptoms? It's a very important question you will have to answer. Can you tell us all the positive and negative sensory symptoms?
Yes, ma'am. Positive and negative sensory symptoms we have for both large fiber as well as small fibers, ma'am. When it comes to large fibers, we have positive symptoms like a cotton wool sensation, a band-like sensation over the abdomen or chest, and negative symptoms we have like numbness. Numbness is a major negative symptom of large fiber. And when it comes to small fibers, positive symptoms can be in case of tingling sensation, pins and needle sensation, paresthesias.
Okay.
And in case of negative symptoms, we have loss of pain temperature. And loss of pain temperature is a major negative symptom in terms of small fibers.
Okay. Now.
And for
yeah, continue.
Yes, ma'am. For motor symptoms, we have positive symptoms like cramps, fasciculations, and negative symptoms like weakness, atrophy.
Very good. So these are important things you should have in mind. Now, which mode of sensation is first lost in peripheral neuropathy and why so?
Ma'am, usually in generalized peripheral neuropathy, it's usually vibration sensation which is usually lost, ma'am. This is usually because vibration, to perceive vibration, our CNS needs to perceive a trail of sensations. It's not a single sensation like a fine touch or position, ma'am, because we have multiple vibrations. The tuning fork is going to vibrate. So even mild disturbance in the peripheral neuropathy, in myelination, there'll be a defect in perceiving this trail of sensations, ma'am. So it gets affected first.
Only in examination we can pick up that, right?
Yes, ma'am.
Now, next, the pain. This patient had some pain and all. No? Next slide.
Yes,
Pain.
ma'am.
Pain here was there. So for pain, there are neuropathic pain, radicular, no, lot of pains are there. Can you
Yes,
tell
ma'am.
me all the types and how you differentiate the like symptom wise?
Yes, ma'am. When it comes to this localizing neuropathies, ma'am, first is radicular pain, ma'am. Radicular pain is usually a sharp, lancinating, and a shock-like pain that usually follows a myotomal or a dermatomal pattern.
Okay.
But and then we have funicular pain. Funicular pain is because of involvement of tracts in the spinal cord, ma'am. This pain is usually a vague pain which is circumferential and usually doesn't have a localizing value. And then
Okay.
we have neurologic claudication, ma'am, which is usually associated with a low back pain and increases on bending down, which increases on standing up and decreases on bending down, ma'am. This should be differentiated with radicular pain, which increases on coughing and with activities. Then
Okay.
neuropathic pain can be again differentiated, can be classified as epicritic pain and protopathic pain, ma'am. Protopathic pain is usually that originates from uh, A delta fibers is vague type and epicritic pain from the C type of fibers, ma'am.
Okay. Okay. So now the next important complaint you're given is unsteadiness
Yes, ma'am.
of gait. So what is your impression with this complaint you have this?
Basically, for a patient for any person to maintain a stable gait, to maintain steadiness, there are three pathways, ma'am. One is the visual sensation, visual input that goes to the parieto-occipital region and to the cerebellum, and then we have the input from proprioception through the dorsal column medial lemniscus pathway and the spinocerebellar pathway, and then from the vestibular apparatus semicircular canals, ma'am. So all these three, all the inputs together go to the cerebellum via the vestibulocerebellar pathway. So if any two of out of these three are impaired, usually patient complains of steadiness, so unsteadiness. So in cerebellum, since all three combine and go to the cerebellum, there is impairment in steadiness and gait in case of cerebellar pathology. But whereas when we want to test dorsal column pathology, usually the proprioception is impaired. So once we ask the patient to close the eyes, or in darkness, when she's in darkness, she will complain of increase in unsteadiness. So this shows that there is impairment in the proprioception pathway. So from the history that she gives, it more likely is it localized to the large fiber dorsal column is a localization based on history.
Okay. Okay. Shanti ma'am?
Okay, yeah. Okay, you're telling about she's having ataxic gait. Is she having? So, what
Yes,
are all the
ma'am.
causes that can cause sensory ataxia?
Cause of sensory ataxia can be either pathologies involving the large fiber uh, neurons in the or the dorsal column pathway, ma'am. So large fiber involving can be peripheral neuropathies like alcohol, diabetes, leprosy, and or vasculitic neuropathies. And then dorsal column we have subacute combined degeneration of cord with vitamin B12 deficiency,
Yes.
tapes dorsalis.
Yes. So few entirely posterior, few maybe posterolateral columns
Yes, ma'am.
that are affected can produce sensory ataxis. Okay, you have told about fever. So what
Yes,
is the
ma'am.
relevance of fever with respect to neuropathies?
Ma'am, history of fever followed by peripheral neuropathy can be a sign of certain infections, ma'am. Number one, if in case of Guillain-Barré syndrome, which produces AIDP, patient usually has a history of fever, illness 2 to 3 weeks prior to the onset of peripheral neuropathy. There can also be in case of HIV diseases where patient may have a low-grade fever that is going on for 2 to 3 weeks or
Okay.
more than that.
Okay, then critical illness polyneuropathy
Critical
also.
illness polyneuropathy, yes, ma'am. And also infections like diphtheria, where patient can have fever, then again present to after 2 to 3 weeks of the initial prodrome, patient can present with neuropathic symptoms.
Okay. Just explain about classification of nerve fibers. You are telling C fibers and other things. How is classification of nerve fibers done? And what are all the fibers associated with hot and cold sensation? Since the patient has lost hot and cold sensation.
Yes, ma'am. We have clinical and anatomical classification of nerve fibers, ma'am. So clinically, we can divide nerve fibers as large myelinated, small myelinated, and unmyelinated fibers. So large myelinated fibers will usually carry sensations like motor sensations, vibration, position, and light touch, whereas small myelinated fibers can carry pain as well as temperature, and unmyelinated fibers usually carry pain, and there is also autonomic sensations, ma'am. And then we have the A alpha, A beta, A gamma, A delta, and B C type of classification. So again, similar, A alpha will carry motor, and A beta will carry vibration. A gamma will carry motor spindle, sensation motor spindle, and A delta with fast pain. And we have B type of fibers carrying preganglionic autonomic, and C type of fibers carrying pain, temperature, and post-ganglionic autonomic. Where here the cold sensations are carried by A delta, and whereas hot sensations are carried by C type of fibers.
Okay, good. So you have told a lot of, go to the next slide.
Yes, ma'am.
There is no sensory disturbance in the upper limbs, only in the lower limbs the patient has.
Yes, ma'am. Upper limb, she didn't complain of any sensory
Okay.
disturbance, ma'am.
Okay. So go to the, okay, what are all the salient features with respect to your negative histories? Where do you get thinning and twitching of muscles? Where you get
Thinning and
diurnal
twitching.
variations?
Yes, ma'am. Thinning and twitching of muscles usually with some symptoms of peripheral neuropathy, you have to think about motor neuron disease, ma'am, where there is involvement of anterior horn cells. So these patients may also have upper motor neuron findings. Diurnal variation, we should think about myasthenia gravis, where there
Neuromuscular
is,
junction disorders. Okay. Then
yes, ma'am, NMJ junction. And we also check for any involvement of cranial nerves sensation, ma'am. So involvement of cranial nerves we need to think about GBS and etc. So that was a negative history regarding cranial nerve involvement.
that are affected with respect to a peripheral neuropathy.
Usually in peripheral neuropathy, when you talk about cranial nerves, cranial nerve one, the olfactory sensation, usually patient has anosmia in case of Refsum disease and also vitamin B12 deficiency, ma'am. And involvement of optic nerve, optic atrophy can also be seen in case of vitamin B12 deficiency, ma'am. And then involvement of 3, 4, 6 nerves, again, it's common with diabetes mellitus,
Okay, especially
diphtheria, yes, ma'am, diphtheria, and involvement of 7th cranial nerve can be seen in case of Miller-Fisher variant.
Okay.
And the involvement of lower cranial nerves usually again is in case of diphtheria and Guillain-Barré syndrome.
We go to the next slide. So joint pain and swelling.
Yes, ma'am. Usually joint pain, swelling in this patient of middle-aged female, again, if there's presence of joint pain, swelling can hint us towards the possibility of autoimmune disorder that can produce vasculitis leading to neuropathies, ma'am. Especially conditions like rheumatoid arthritis, SLE, which have constitutional symptoms of joint pain or weight loss can result and recurrent on and off low-grade fever. They can be associated with peripheral neuropathy.
Okay, oral and ulcers, skin ulcers, again the same. Or any other thing you want to add? No history of recurrent oral or skin ulcers. How significant it is? Patches on the skin.
Yes, ma'am. Patches in the skin usually to rule out leprosy, Hansen's, and oral again ulcers in case of autoimmune conditions. Vitamin B12 deficiency, pyridoxine deficiencies, so water soluble vitamin deficiencies, ma'am.
What about autonomic abnormal sweating bowel bladder in association with peripheral nerves?
Involvement of autonomic nervous system in peripheral nerve, usually we have to think about number one, diabetes mellitus, ma'am. Then amyloidosis usually has involvement of autonomic neuropathy. Then there is pure autonomic involvement pattern of peripheral neuropathy seen in case of porphyrias.
So abdominal pain, test towards porphyria.
Yes, ma'am.
or-
Abdominal pain towards porphyria.
Okay. So go to the next slide.
Continue.
Yes, ma'am. Regarding past history, patient was a known case of a hypothyroidism diagnosed 10 months back, for which he was on regular treatment. And
So
patient also
even
gives.
hypothyroid, you can have carpal tunnel syndromes and other things. Okay, that also.
Yes, ma'am. Yes, ma'am.
Okay.
And
Okay.
also patient gives a history of recurrent admissions for wound care, and also she had gives a history that she had received monthly injections for the last 6 months, ma'am, for her illness. And there
So
was
what
no
is
history.
it probably?
Ma'am, monthly injections, considering ulcer, the possibility of vasculitis for which she might have been given on immunosuppressive injections, a possibility, ma'am. Or vitamin B12 injections, where we give initially for 5 days followed by monthly injections, is
Okay.
also a possibility.
Oh. Okay. Sexually related transmitted diseases and peripheral neuropathy.
STDs, usually we have HIV, which is associated with a myriad of presentations for peripheral neuropathy, ma'am. So most common being a distal sensory motor peripheral neuropathy, which is most common HIV. There can also be polyradiculopathy, and also be AADP like presentation, which usually occurs during the seroconversion phase of HIV. And patients might also have a symmetric distal proximal polyradiculopathy like CIDP during any phase of HIV, usually once they get into the AIDS syndrome.
What about toxins and peripheral neuropathy? There are a lot of things. Toxins and peripheral neuropathy.
If some history of exposure to toxins can give us multiple clues, from like example, mercury, lead, thallium, arsenic. Each has a specific point which can help us come to the help in our diagnosis. For example, lead, it's usually a motor neuropathy that presents with foot drop and involves both upper limb, lower limb, wrist drop. And then we have thallium, where patient may have curly hair and alopecia, and patient may also have in case of arsenic exposure, where there can be autonomic symptoms with multiple skin changes like raindrop pigmentation, Mees lines.
Okay. Next slide.
Hypothyroidism, what will you think of?
Hypothyroidism most commonly presents with entrapment neuropathies, most common being carpal tunnel syndrome. Very rarely it can present with the distal sensory motor neuropathy.
Then diabetes is an important thing, no? Tell about diabetes with neuropathy before going to the next thing.
Yes, ma'am. Diabetes mellitus most commonly again presents with the DSPN, distal sensory motor polyneuropathy. And diabetes can also present with pure autonomic symptoms, autonomic neuropathy. It can also present with lumbosacral brachial plexopathy, called diabetic amyotrophy, where there is a history of severe weight loss. And it's a very painful neuropathy, usually involving the thighs and legs.
Okay.
And
Then
there is also diabetic pseudotapes. Yes, ma'am.
Drugs. No? Important history you should ask.
Drugs.
Commonly prescribed drugs like nitrofurantoin, metronidazole, phenytoin can result in an axonal type of peripheral neuropathy. Whereas in case patients with cancers with a history of chemotherapy, they can result in drugs like cisplatin, paclitaxel, thalidomide. They can result in neuronopathies.
Okay, continue.
Yes, ma'am. Coming to personal history, patient takes a mixed diet. She is not a tobacco chewer and not an alcoholic or smoker. And there's no history of intake of any complementary alternative medicines. Obstetric history, she's a P3, L3, all normal vaginal deliveries. Sterilization has been done. LMP is 28/8/24.
Okay, so what is the importance of alcohol? Very important common causes.
Alcohol again usually presents with a painful distal sensory neuropathy, but alcoholic patients, in case of pure alcoholic neuropathy, but usually these patients also have multiple vitamin deficiencies, most commonly being thymine deficiency, ma'am. So once there is thymine deficiency, there are multiple presentations where there can be involvement of both distal as well as proximal small fiber, large fiber neuropathies are present, can be present.
Okay, very good. Now this complementary alternative medicine.
These CAM, usually patients take medicines without knowing, because many of Ayurvedic preparations, they have heavy metals in them, ma'am, like mercury, etc., which patient may not be knowing but be taking for for the overall health benefits, which might result in a chronic intake during a chronic duration, result in neuropathies.
Okay, so that's
Yes.
a very important history to be taken. No, CAM
Yes, ma'am.
history is very important. Okay, next slide.
There is no history of similar illness in the family members, ma'am.
So very important, like X-linked diseases and all, no?
Yes, ma'am. Fabry's disease, like Tanger's disease, can be there. And again, there are multiple variants of Charcot-Marie-Tooth disease,
Yes.
which again present, for example, CMT1 is autosomal dominant, CMT3 is autosomal recessive.
Yeah. So
Complete the 3 generations you have to put. It is there. So no such history is there.
Yes, ma'am. No history of any similar illness, that family members did not have any history of difficulty in walking or any flat foot or using crutches during their end of life.
Oh,
okay. Summary.
Yes, ma'am. Summarizing the case. Ma'am, summarizing the case, here we have a 42-year-old female who is a known case of hypothyroidism, presented with insidious onset, gradually progressive chronic neurological illness in the form of symmetric distal burning paresthesias of lower limb, symmetric distal loss of pain and temperature, unsteadiness of gait with cottonwool sensation, and distal motor involvement of lower limb in the form of difficulty in clearing obstacles in ground. There is no history suggestive of involvement of proximal muscles, cranial nerves, bladder or bowel, cerebellum, extrapyramidal, autonomous nervous system, or higher mental function. Based on this history, the structures, I would like to localize the structures as distal symmetric small fibers of lower limb, and distal symmetric large fiber motor and sensory of lower limb.
Okay, good.
So-
That put that approach to peripheral neuropathy, no? That Harrison's.
Yes, ma'am. Based on this history and structures involved, to come to a initial differential diagnosis, we need to ask the 7 basic questions that we have to ask ourselves,
Yes.
so that we could come to a possible differential diagnosis of the patient now.
Okay.
So the first thing would be, what are the systems, or what axis of the peripheral nervous system are involved, whether it is motor, sensory, or autonomic.
Yes.
Second is, what is the distribution of weakness, whether it is proximal or distal. And the second question, or second part of this question would be whether it is a symmetric or asymmetric.
Yes.
Third would be, what is the nature of sensory involvement? Does it involve pain, temperature? Basically, we need to make sure whether it's a small fiber or a large fiber involvement.
Yes.
And then it would be whether are there any signs of human involvement to rule out anterior horn cell, like motor neuron disease. And then fifth would be the temporal distribution, ma'am. So if it's acute illness for 1 to 4 weeks, we say it's a acute neuropathy, and 4 to 8 weeks it's a subacute, and more than 8 weeks it is a chronic neuropathy.
Yes.
And next would be whether evidence of hereditary neuropathy, like flat foot or pes cavus or hammer toes, or scoliosis. So to look for hereditary neuropathy. And the last would be, are there any comorbidities like hypothyroidism, SLE, or known vasculitis? So based on these questions, when we apply these questions to our patient, so number one, our patient has both a sensory and motor involvement, and the distribution of weakness would be distal and symmetric. And nature of sensory involvement is both large fiber and small fiber, ma'am. And there is no human involvement, and the temporal distribution is chronic. So based on this, it would be a chronic distal asymmetric motor sensory involvement. So based on this, the differential diagnosis for my patient would be considering the age and the presence of ulcer, which is an important clue. A vasculitis associated neuropathy would be a consideration. Number two would be a metabolic associate like a diabetes mellitus. Three, a drug or toxin exposure, toxin induced peripheral neuropathy. Fourth would be amyloidosis or monoclonal gammopathies involving induced peripheral neuropathies. And the fifth would be a cryptogenic idiopathic peripheral neuropathy, since it fits the pattern. And the last would be a paraneoplastic involvement or paraneoplastic process that is occurring in the patient due to cancers.
Yeah, okay. So I think you have
Go for the
clearly
examination.
pointed out based on what Harrison gives, no, these questions.
Yes, ma'am.
So it's very easy to come. Metabolic, what will you think of if it is metabolic?
Diabetes mellitus would be the first differential, ma'am, in this patient.
Yes,
In case once you think of metabolic.
metabolic. And vasculitis, what can be the possibility? Though we don't have any history, so at this
Yes, ma'am.
point we are not very clear, no, unless we investigate.
Yes, ma'am.
Amyloidosis is quite rare. So cryptogenic, maybe 50% after ruling out everything, we can bring
can-
it back.
Yes,
Yeah,
ma'am.
it should be a diagnosis of exclusion.
At the end.
Paraneoplastic, we should always keep in our mind. Though
Yes,
there
ma'am.
is no history of weight loss. Weight loss history, is it there?
And no history of weight loss, no history of significant weight loss.
Yeah. So, still we should always have that in mind, right? In this way.
Yes,
So,
ma'am.
okay. Dr. Pavitra, can you go on for your examination?
Yes, ma'am. General examination. Patient is conscious, oriented, cooperative, well-built and nourished, ma'am. No pallor, no ictus, no clubbing, no pedal edema, no lymphadenopathy. Skin changes, there is a mild hyperpigmentation over the medial malleolus of left foot present, ma'am. But there is no any hypopigmentation, no livido reticularis, no purpura, no rash. Nails look lusterless in the lower limb, ma'am, but there is no associated with color changes. Graying of hair present, ma'am. Oral cavity examination is normal, tonsils are normal, teeth is normal. There are no neurocutaneous markers. There are no peripheral nerve thickening. There is no hand and foot deformities. There is no kyphoscoliosis. Thyroid and breast examination is normal, ma'am. Local examination of the left foot. There are two ulcers, one of size 4 cross 3 cross 1 in the lateral aspect of a heel and another of size 8 cross 5 cross 2 in the medial aspect of the heel with the slough and the granulation tissue is present without any active pus, sir. There's a bilateral fruit drop present, ma'am.
Okay. Just go back to the previous. Okay, this is the ulcer.
Yes,
Okay.
ma'am.
Okay. In general examination, is there any pallor? Pallor
Patient
and
doesn't have any pallor, ma'am.
anemia and neuropathy. What are all the causes or how?
Either it could be because of nutritional deficiencies, ma'am. Either it could be because of vitamin B12 deficiency or any other malabsorption syndrome, sir. Or it could be because of toxin exposure like lead, which causes anemia along with the peripheral neuropathies, ma'am. Any cachectic state or any connective tissue disorder associated with loss of weight and
Anemia of
loss of
chronic
appetite
disease.
can
Anemia
be
of pattern of anemia of chronic disease. With respect to B12, it may be macrocytic.
yes, ma'am.
Okay. All types of anemia may be there. Okay, lymphadenopathy and neuropathy.
Probably any paraneoplastic or lymphomas can have multiple lymphadenopathy, ma'am. And Castleman disease can present with lymphadenopathy and peripheral neuropathy. Refsum's hereditary condition, refsums can present with lymphadenopathy, ma'am. Then Tanger's disease can present with lymphadenopathy, ma'am.
Okay, neuropathy is associated with peripheral nerve thickening.
My first commonest thing is leprosy, ma'am. Then probably hereditary motor neuropathies can be associated with the peripheral nerve thickening. Refsums can be associated, ma'am. Then neurofibromatosis can be associated with peripheral nerve thickenings, ma'am.
So in head to foot examination, what are all the markers that can be there for peripheral neuropathy?
First, I should look for a hair, ma'am. Either it could be alopecia, probably acute in case of thallium condition. Then it could be scarring and non-scarring alopecia associated with connective tissue disorder like SLE, ma'am. Then I should look for eyebrows, ma'am. Madrosis can be seen, which is associated with leprosy, ma'am. Then I will look for any skin changes, ma'am. One is hyperpigmentation. Skin changes can be seen over the knuckles in case of vitamin B12 deficiency, or overall hyperpigmentations can be seen in some sort of hereditary neuropathies, ma'am. Hypopigmentations can be seen. Hypopigmentation patch can be seen in leprosy, ma'am. In case of toxic exposure, there is a raindrop pigmentation, alternative hypopigmentation and hyperpigmentation patch can be seen, ma'am, in arsenic kind of exposure. Then I should look for any pest cavus or hammer toes, which are commonly seen in Charcot Marriott varieties. And Friedreich's ataxia can present with deformities along with the scoliosis, ma'am.
Okay. Okay, so there is an ulcer, whether it is a venous ulcer or arterial ulcer, or it is, you are telling it is maybe a vasculitis. How to go about?
Ma'am, in this case, the patient attained ulcer unknowingly after she come in contact during the heart vessel during cooking, ma'am. Usually, venous ulcer are commonly present over the medial aspect of the foot due to stasis, and that will be associated with hyperpigmentation, and they're associated with itching and all, ma'am. In case of arterial ulcer, which are commonly present in the anterior aspect of leg, and it is very deep and dry, ma'am, with the discoloration of skin can be seen along with absent peripheral pulses, ma'am. In case of vasculitic ulcer, patient can have initially it started with a deep punched out ulcer, ma'am. And since the healing nature of the ulcer is delayed in case of vasculitis, they can be changed into tropic ulcer, ma'am, mostly present over the lower limbs.
So in neuropathy, what are all the autonomic symptoms the patient can have?
Ma'am, in history wise, we should ask for history of any fainting episodes or syncope episodes. Then there is a decreased sweating, ma'am. Anhidrosis can be seen. Then there is history of postprandial blotting sensation, ma'am, associated with the bowel and the bladder disturbances. Constipations can also be there.
Diabetic autonomic neuropathy, alternating bowel habits may be there.
Yes, ma'am.
Okay. So how will you look for autonomic nervous system? How will you?
Ma'am, there are some. First, I should look for postural hypotension, ma'am. So I will examine the patient in the supine position, ma'am. Then for the 3 minutes after supine
Go
position.
for the vitals. Have you completed the vitals?
No, ma'am.
Along with that, you can explain. Go to the vitals. Okay.
Patient pulse rate 72 per minute, regular, normal volume, no specific character, felt in all peripheral pulses equally. BP is 120 bar 80 millimeter of mercury, which is measured in the supine portion. After standing portion, measured after 3 minutes, ma'am, there is no any postural drop, ma'am. BP is 110 bar 70 millimeter of mercury. Lower limb BP in both sides is 130 bar 80, ma'am. Respiratory rate is 16 per minute. Saturation is normal. The temperature is 98.4 degree. Weight is around 55 kg, ma'am. Height is 152. So BMI is around 23.8, ma'am.
Okay.
So,
okay, go for the next slide. Okay, proceed with CNS examination.
CNS examination, mini mental state examination is 30 by 30, ma'am. Cranial level examination, sense of smell appreciated in both nostrils equally. Visual acuity is around 20 by 50, ma'am. Field of vision, confrontation test is normal on both
Cranial
sides.
nerves are basically normal, is it?
Yes, ma'am.
Fundus?
Fundus examination is also normal in this patient, ma'am.
Okay, no optic atrophies, nothing
No,
is
ma'am.
there.
No.
So can you
What
tell all
do
this cranial nerve with the peripheral neuropathy before
ma'am.
going to the next?
Coming into first cranial nerve, anosmia and the sensory disturbances can be seen in refsims and vitamin B12 deficiencies, ma'am. Then coming into third cranial nerve, isolatedly it can be present in diabetic neuropathy, where it is pupillary sparing neuropathy, ma'am, mostly, and that is associated with the sixth nerve, lateral rectus palsy. Then mainly trigeminal sensory nerve is involved in the case of jaw grunts, ma'am. Probably then seventh nerve is involved in leprosy and sarcoidosis and GBS can be involved, ma'am. In Miller-Fisher variant, the third and fourth nerve can be involved, ma'am. Lower cranial nerves are involved in GBS type of neuropathies, and Kennedy syndrome can also be seen, ma'am.
Okay.
Diphtheria.
Diphtheria can also have lower.
Fundus.
Ma'am, I will see for diabetic retinopathy changes, ma'am. Since it is 42 years, so she's not aware of her metabolic status. Then
Yes.
I should look for any retinitis pigmentosa changes, ma'am. Then
Where
any
will-
PAP, ma'am.
What condition?
Ma'am, retinitis pigmentosa can be seen in Refsum's disease or any kind of mitochondrial diseases, ma'am.
Even in Tangiers, you can get
Yes, ma'am.
Tangiers disease. Retinitis pigmentosa. Yeah,
Yes,
yeah, absolutely.
Cranial examinations are normal, ma'am.
Okay, go for the motors. Okay.
Finomotor examination. Bulk is on inspection, there is no obvious wasting of any muscles. Measurements, ma'am. Arm is around right and left 27 centimeter. Forearm is
I can skip. Okay, there is no disparity, no?
no, ma'am.
Okay, just proceed.
Upper limb tone is normal on both sides, and lower limb tone is normal on both sides, ma'am.
Okay.
Then coming into power examination, upper limb power is normal, ma'am. 5 by 5 in all joints, ma'am. Shoulder is also 5 by 5 in all movements. So then coming to lower limb examination, hip flexion, extension, adduction, abduction, internal rotation, external rotation are 5 by 5 on both sides, ma'am. On coming to knee joint, flexion and extension are 4 minus and 4 minus, ma'am. Coming to ankle joint, dorsiflexion is 0 by 5, ma'am. Plantar flexion is 2. And inversion and eversion are 0 by 5, ma'am. On
Okay.
both sides.
Yeah, so it looks like foot drop. The
Yes, ma'am.
anatomy of it, no, before going.
Ma'am, either foot drop can be due to peripheral neuropathy or common peroneal nerve injuries or any radiculopathies, ma'am, especially L5 radiculopathies or because of any motor neuron, especially peroneal nerve disease also can cause a foot drop, ma'am. If
Yeah.
it is because of L5 radiculopathy, it is associated with abduction, hip abduction deformities can be seen, and sensory pattern will be along the route of L5, ma'am. But patient can also have radicular pain in the sensory distribution, ma'am.
Okay.
Sciatica can also have foot drop, ma'am.
Okay. Muscles of dorsiflexion, plantar
Ma'am,
flexion.
yes, ma'am. Dorsiflexion is mainly due to tibialis anterior, ma'am. Then plantar flexion is due to gastrocnemius soleus plantaris and peroneus longus. Then inversion is because of tibialis anterior and tibialis posterior, ma'am. Eversion is mainly due to peroneus longus, brevis, and tracheus, ma'am.
Oh. Okay. Continue.
Then this is
So she's not able to do.
not able to do the dorsiflexion, ma'am.
Okay. Plantar also she's not able to do.
Plantar foot drop is there, ma'am, but resistance she is not able to do.
Okay. Then
Coming into superficial reflexes, cardial, conjunctival, palatal, and abdominal reflexes are present. Plantar, there is no response, ma'am, on both the sides.
okay.
Coming to DTR, jaw jerk is absent, ma'am. Biceps, triceps, supinator are 2+ on both sides. Knee and ankle are absent, ma'am.
Okay.
Coming into sensory system examination, pain perception is completely absent in all the aspects of the
Continue.
all aspects of the foot, ma'am, but it is decreased up to the mid-calf levels and it is normal above that level, ma'am. Proximal lower limbs pain sensation is normal, ma'am. Then pain sensation is equal in upper limbs, trunk and back, ma'am. Then hot and cold sensation are absent in both the feet and it is decreased up to the mid-calf levels, ma'am. Above that level, all are not. And coming into posterior column sensation, fine touch is absent in both dorsal and plantar aspect of the foot, ma'am, till ankle. And above that, it is normal, ma'am. Sacral sensation is also intact, ma'am.
Okay.
coming into timed vibration, in grade 2 metatarsal joints and medial malleolus, it is absent in both the sides, ma'am. Tibia, patella, it is around 8 seconds on both sides, ma'am. In anterior superior iliac spine, it is around 10 seconds, ma'am.
Oh,
In upper limb, in DAP and wrist joint, it is around 15 seconds. Olecranon, it is 15 seconds on both sides. And clavicle, it is 18 seconds on both sides, ma'am. This is the pattern of sensory involvement in our case, ma'am.
okay.
Coming
So,
into joint position sense, she's not able to perceive the joint sense and motion sense in the metatarsal joints of both the lower limbs and ankle, ma'am. Upper limb joint sensation are normal, ma'am. In coming to deep pressure examination, she's not able to perceive the pressure when squeezing the Achilles tendon, ma'am. Then rhombox is positive, ma'am.
so how will you test for vibration sense?
First, I will give instruction to the patient by I will keep
What is
striking
the
the tuning
frequency
fork.
that you use? What is the frequency of tuning fork?
128 hertz,
Start
ma'am.
from the okay.
First, I will give instruction to it by striking the rubber cork over the tuning fork. Then I will give that tuning fork over the sternum, ma'am, to give instruction for the patient. Whether she is able to feel the touch or it is vibration. Then after giving instruction, I will place that tuning fork over the distal joints, ma'am. First, to start with the lower limb or the great toe. We will see whether she is able to perceive the vibration or not, ma'am. If it is not seen, I will not proceed. I will proceed with the next proximal joint, ma'am. If it is present in the distal limb, I will not proceed with the other joints, ma'am, since distal most is perceived.
What about over the spines in this patient?
Spinal vibration is normal, ma'am.
Oh.
Oh. Oh. Which condition you get reverse of peripheral neuropathy? Means more of scalp, face, proximal limbs, but distal not involved. Any idea?
Prox-
Please, no?
Tangers can be
Yeah, that is that. And what are color of tonsils? Tonsils.
orange color tonsils can be seen in tangers, ma'am.
So do you know what is the problem in tangers?
Ma'am, that is probably because of decreased HDL levels and increased triacylglycerol levels due to ATP binding cassette mutations, ma'am.
Increase in very low
Very low
chain
levels, yeah.
fatty acids are increased, ma'am. So they get accumulated and they result in.
Yeah, very good, very good. Yeah. Okay, continue.
Coming to cerebellum examination, finger nose finger test is she is able to perform, ma'am. Then heel knee shin test she is able to perform, ma'am, but there is a weakness over the feet lesson, ma'am. Tandem walking she is not able to perform, ma'am. Speech is normal. Rapid alternating movement she is able to perform, ma'am. Then this is the gait of our patient, ma'am. She's having a high stepping gait. Patient uses her toes first, ma'am, while walking, and she uses the support of her upper limb while walking, ma'am.
Very good, very good.
My extrapyramidal system, no, there is no bradykinesia, there is no rigidity, there is no tremors, ma'am. Coming into autonomic nervous system, there is no resting tachycardia and there is no postural hypotension, ma'am. Spine and cranium is normal. There are no signs of meningeal irritations, ma'am. Other system examination, CVS S1, S2 present, there is no murmur. R is normal vesicular breath sound present. Abdomen soft, bowel sound present, and there is no organomegaly, ma'am.
Okay, go for your impression.
Yes, ma'am. Coming into case summary, a 42 years old female presented with insidious onset, slowly progressive chronic neurological illness, which started around 10 months back with burning paresthesia, pain, and followed by numbness of both lower limbs and gradually extended from sole to mid calves with history of unaware slippage of footwears, followed by distal small muscle weakness in the form of difficulty in walking, ma'am. Then coming into positive examination findings, patient is having bilateral foot drops, probably because of the weakness of dorsiflexors, invertors, evertors, and mild plantar flexors. Ma'am. Then there is loss of pain, temperature in both the feet up to ankle joint, decreased up to mid-calf region, ma'am. Probably this could be because of involvement of spinothalamic tract. Then there is a loss of vibration, joint and position sense in both the feet, involvement of posterior column, dorsal column. Ma'am. Then tropic ulcer over the left foot. Negative finding, there is no proximal involvement in lower limb and there is no upper limb involvement. There is no cranial nerve involvement, cerebellum and autonomic involvement.
Can cranial nerve alone get involved? In
Yes, ma'am.
peripheral?
Isolatedly, it can be present in diaptic, isolated third nerve cranial nerve palsies or isolated sixth nerve cranial nerve palsies.
Yes. Okay. Polyneuritis cranialis, what is it? The multiple cranial nerve involvement.
Multiple.
So it can be due to one idiopathic, or it can be due to inflammations like tuberculosis,
Yes, ma'am.
elephantiasis, sarcoidosis,
Yes, ma'am.
even intracranial malignancies like carcinomatous meningitis, no?
Yes, ma'am.
Have only cranial nerve involvement.
Okay, ma'am.
Okay. Continue.
Then diagnosis, probably this is a case of bilaterally symmetrical large fiber and small fiber, distal predominant, length dependent sensory motor polyneuropathy. My differential diagnosis could be vasculitis, and the second can be it is metabolic, and the third can be amyloidosis, and fourth it could be cryptogenic or idiopathic. Lastly, I could think of paraneoplastics.
Okay. 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 So what investigations?
Coming into investigations, we will proceed with complete blood count, ma'am. Whole white blood cells, HBs, and the platelet count. Then I will proceed with the renal function test, the liver function test. Then we'll see for electrolytes. Then I will look for any creatinine kinase levels, ma'am, associated with any motor predominant neuropathies.
How does porphyria will present? Polyneuropathy due to porphyria. What will be the presentation like?
Ma'am, they can present with acute onset abdominal pain, nausea, vomiting with psychiatric manifestations, ma'am.
All these,
All-
after 2 to 3 weeks following these symptoms, patient will have a proximal plus distal presentation of neuropathy, similar to Guillain-Barré syndrome. But one thing to differentiate would be the ankle reflex will be preserved in porphyria. The exact reason is not known. And also porphyria, yes, ma'am.
Yeah. Okay. And you can have tachycardia, hypertension, no? Autonomic.
Yes, ma'am.
Yes, ma'am. Autonomic symptoms.
So that is one thing. And port vein colors, urine.
Okay,
Yes, ma'am.
On exposure to light.
right.
Very important. So abdominal pain, psychotic symptoms, convulsions, as Adan rightly told, no, motor neuropathy with port veins colored urine on exposure to light. Treatment?
Yes, ma'am.
You have any idea?
Ma'am, treatment we initially give glucose, ma'am.
Yeah.
And if the patient doesn't settle, then we go for we wait for 48 hours. Then we go for hematin. We give for 3 days.
And beta blockers for hypertension,
Yes, ma'am.
tachycardia, which will be there. So IV glucose is to suppress the heme
Heme
bios.
backwards.
That is very important. Though it's rare, you should know because treatment is very easy. You can start directly IV glucose.
Yes, ma'am.
And usually precipitating factors like drugs and all will be there. So
Yes,
that
ma'am.
is very important to be thought of. And Hansen's, you should never forget, always look for the thickening of the nerve.
Very fine. Yes, ma'am.
What next investigation?
Ma'am, we'll proceed with the thyroid function test, ma'am. Patient is a known case of hypothyroid and she is on drugs, ma'am. So our TSH and free T4 is normal. Then we'll proceed with viral markers. Her VDRL is non-reactive, HIV 1 and 2 are negative. And since she is a 42 years old female, we'll proceed with CTD and vasculitic related panel, ma'am. So we sent ANA, which is weekly positive, and anti-SSA and anti-ROS positive in this case, ma'am. So any neuropathy will proceed with the NCS, ma'am. Coming into this case, motor NCS is bilateral posterior tibial and bilateral common peroneal nerve are not stimulatable, ma'am. Coming to sensory NCS, bilateral sural nerves are not stimulatable, and F waves are not obtained in both bilateral common peroneal and bilateral posterior tibial, ma'am. Then, since for a diagnosis, we have proceeded into muscle and nerve biopsy of this case, ma'am. In which superficial peroneal nerve and peroneus brevis muscle, there is a necrotizing vasculitis, like feature is seen in this case, ma'am.
Okay, so why superficial peroneal nerve and sural nerve are selected for nerve biopsy?
Ma'am, superficial peroneal nerve and sural nerve are selected because they are pure sensory nerves, ma'am.
So when-
Even we do biopsy, there is no motor weakness after procedures, ma'am. So we choose that.
So here we have this Jogrens, no?
Yes,
Because
ma'am.
SSA and anti-Rho positive.
Yes, ma'am.
So neuropathy is a presenting feature of Jogrens.
Jogrens, ma'am.
Okay, next.
Ma'am, we also did screening of MRI just to rule out the presence of any compressive myelopathy, which did not show any significant findings, ma'am. There was no significant spinal cord narrowing.
Okay, before that, electrodiagnostics you did know. How will you differentiate whether it's an axonal type or demyelinating type? Yes.
Ma'am, coming into motor NCS, I look for a C map, ma'am. The amplitude will be decreased in axonal type, but distal latency, conduction velocity, and conduction block will not be there. But distal velocity and distal latency and conduction velocity will be normal, ma'am. Then I look for temporal dispersion, ma'am. It is not seen in axonal, but temporal dispersion is seen in demyelinating type, ma'am. Then F wave can be normal or absent in axonal, ma'am. It is present in case of demyelinating, and H reflex is normal or absent in case of axonal, and it is present or a normal can be seen in demyelinating, ma'am. Coming into sensory NCS, I will look for SNAP, ma'am. It is this amplitude will be decreased in case of axonal, and it will be normal in case of demyelinating. And distal latency and conduction velocity will be normal in case of axonal, and it will be abnormal in case of demyelinating, ma'am. Then
So
we
in
will
these
proceed,
cases, it is not conclusive
ma'am.
because it is not stimulatable. What in your case,
Yes, ma'am.
there is no conclusion because it is not stimulatable. Is it so?
Yes, ma'am. As there is no sensory, there is no motor fibers are completely damaged. They are not stimulatable, ma'am.
So that is the reason they have
They
proceeded. with
proceeded
muscle
into
and-
nerve
biopsy.
biopsy and muscle biopsy.
Okay. Okay.
So what are the indications for nerve biopsy?
Ma'am, probably even after a panel of investigations, if we are not able to come into conclusion, especially the cases which involve predominantly small fiber neuropathies, ma'am, or else vasculitic and amyloidosis can be picked up only by nerve biopsy or muscle biopsy in
So
some
mainly
cases.
like in Hansen's amyloidosis, vasculitis,
Vasculitis, ma'am.
archidosis and all, no? So you
Yes,
have,
ma'am.
so nerve thickening is there. And in small fiber myopathy, I mean, neuropathy, the demyelination, the decrease in demyelination, that
Yes,
is by skin biopsy, right?
Yes,
Yes,
ma'am.
ma'am.
Yeah, that is how you can make out for small fiber. Of course, these, so it's very
What
important.
are all the investigations you do for paraneoplastic workup? Or
We usually look for antibodies, ma'am, like anti-Hu antibodies, anti-Nafsin antibodies, which are mostly involved in paraneoplastic cancers, with CA lung being most common, followed by CA breast and gastrointestinal tumors.
So you should know about myelinopathies and neuropathies.
Yes,
And then
ma'am.
axonopathies.
Yes, ma'am.
Axonopathies are causes like trauma, alcohol, uremia, porphyria, diabetes, and myelopathy is GBS,
Yes,
even
ma'am.
diabetes, diphtheria, head neuropathies. All these are fine differences, but you should be able to tell.
Okay. Yes, ma'am.
Okay.
Yes, ma'am.
Then even genetically caused like gent axonal neuropathies, metachromatic leukodystrophy, all that will do nerve biopsy. Otherwise,
Yes,
it's not all the cases you go and keep doing the nerve biopsies.
Yes, ma'am.
Okay. So final diagnosis for this patient?
Final diagnosis, it's a case of distal
Predominant.
predominant symmetric sensory motor polyneuropathy, which was a presenting complaint of vasculitis at Sjogren syndrome. So in these patients, so patients with Sjogren syndrome present with vasculitis and neuropathy, especially. There have been trials which had tried the efficacy of glucocorticoids and cyclophosphamide and glucocorticoids with rituximab, but both have been equally efficacious. So in this patient, we went on with cyclophosphamide, 800 mg monthly once for 6 doses with high dose glucocorticoids initially, and now patient is on tapering dose.
Okay. Patient was admitted for this ulcer, is it?
Yes, ma'am. This time she was admitted for this ulcer.
Okay. Shanti ma'am, shall we wind up the thing? Shanti ma'am?
How will you monitor or how will you follow up the patient with all these drugs or all these investigations, or what toxic effects, side effects you will observe when the patient is on cyclophosphamide, prednisolone?
Ma'am, with we need to look for frequent CBCs, and number two, we also keep a close watch on the sugar control of the patient, ma'am, with FBS, PBS, because patient being on steroids can go in for diabetes and complications of steroid complications, ma'am. And also with cyclophosphamide, considering the age of the patient, the other gonadal toxicity is less, but again, cyclophosphamide, we also look for secondary malignancies with cyclophosphamide.
Okay,
What,
very
and ulcer care you have to have, and the proper
Yes, ma'am.
slippers in the modified way you can have an opinion and you can issue.
Yes,
Okay.
ma'am.
Then the ulcer also.
Then a few words about autonomic neuropathy, no? That is important. So causes like diabetes,
Diabetes mellitus, amyloidosis, porphyrias can have autonomic neuropathy.
autonomic
And even,
side dragger syndrome.
yes, ma'am.
Familial
multiple
dysautonomias can be seen, ma'am.
Yes. So
Then in CNS exam, Parkinson can also present with
yes. Autonomic, no? That is
autonomic
Yes, ma'am.
neurosis.
so they
GBS
also have this
have
term called negative and positive phenomenons. Okay.
Again, GBS
Okay, ma'am.
have autonomic.
Yes,
Negative,
Okay.
dry mouth, dry eyes, hypothermia. There's
Yes,
a
ma'am.
syncope you told, bladder atony, and blurring of vision. And
Yes, ma'am.
positive like hypertension, tachycardia, bradycardia,
Bradycardia.
hyperhidrosis, and diarrhea.
Yes,
All
ma'am.
these are thick. So we have to treat if they have all these autonomic neuropathy. These
Yes,
are
ma'am.
the two important questions which will be asked.
Yes, ma'am.
Okay. Ma'am, shall we wind up the session if it is?
Yes. What about Palaniappan sir and Meenakshi Sundaram sir? Are they in line? And
I
Vijay
don't-
Anand sir, if you want to contribute, you can contribute, sir.
I think nobody is there, madam. Only we are there.
Okay. Okay, ma'am.
Okay. Thank you,
Thank
Dr. Vadan
Thank you, ma'am. Thank you, ma'am.
and Dr. Pavitra. Excellent presentation.
Thank you.
Thank you all for hearing the class. Thank you all.
Thank you, ma'am.
Thank you.
Thank you.